Hello, everyone. I'm Sharia Robinson, and a nursing student at McKendree University in Nursing 609, where we are studying philosophical and theoretical foundations for nursing education. And I will be discussing emergency contraception and the nurse educator as it relates to ethical and legal challenges in nursing education. Emergency contraception, history and introduction. I will discuss here briefly about the understanding of conception, um, the earliest 1500 BC, and the controversial conversations that went on throughout our history. Emergency contraception is defined as any birth control method that can be used to prevent pregnancy after unprotected sexual intercourse. Other names used for emergency contraception is also called Plan B, which is now actually a brand name of a product that can be bought in some stores in the United States. It's also been called the morning after pill and also called post-coital contraception. There's evidence that emergency contraception has been studied and tested since 1500 BC when humans found out that seminal fluid caused pregnancy. Historically, several home remedies were used after sexual intercourse years ago, and some people may even practice it today. Some methods are called withdrawal method. Some use herbs and rubs to deactivate the seminal fluid to render it ineffective. Some women actually posed in different body positions, and some actually used douches containing spermicidal cocktails, which was still being used in the 1980s. In the late 1950s, hormonal therapy was introduced for routine birth control and emergency contraceptive. Throughout the 60s, 70s, and 80s, we've made major advancements, and now emergency contraceptive is more easily accessible. As far as the controversial, it was controversial then and it still is now. Healthcare workers as well as members of society hold different opinions about emergency contraceptive, whether it disrupts the fertilized ovum or prevents it from being fertilized. This is where the dilemma lies. Here we will discuss unintended pregnancy, social determinants, the law, and sexual health. I was so delighted to find that one of my very own nurse practitioners here from Louisville, Kentucky, Ms. Kit S. Devine, a nurse practitioner and director of Fertility and Endocrine Associates and co-owner of the Louisville Reproductive Center, has authored one of the sources that I decided to use called The Underutilization of Emergency Contraception, Examining the Reasons Underlying this Clinical Gap in Healthcare. Ms. Kit defined, or actually talks about some of the stats. And according to Ms. Devine, 1994 and between 1994 and 2001, nearly half of all U.S. pregnancies were unintended, with 48% occurring despite the use of contraception during the month preceding the pregnancy. In 2006, the overall rate of unplanned pregnancy in the United States was 52 per 1,000 women between the ages of 15 and 44. But the rate among poor women was 5 times that of women in the highest income level. Some of the disparity is related to cognitive functioning, access to reproductive health education, and lack of effort from health educators to ensure vulnerable populations receive the education they need and deserve. Some of the law that I found talks about since the late 1990s, state legislators have taken steps to expand or restrict women's access to emergency contraception. For example, in Illinois and Washington state, they stipulate that pharmacists that stock any form of birth control must sell emergency contraceptive pills. Several states require healthcare facilities to offer emergency contraception to all women who present and report sexual assault. Other states have excluded emergency contraception from state Medicaid family planning programs and have not been able to expand the contraceptive coverage mandates. In other words, they have actually removed the insurance coverage under the Medicaid plan for emergency contraceptives. Here we will discuss unintended pregnancy, social determinants, the law, and sexual health as it relates to emergency contraception, and review a little bit more history. I was so delighted to find that one of our very own local nurse practitioners here in Louisville, Kentucky, is actually the clinical director of Fertility and Endocrine Associates and co-owner of the Louisville Reproductive Center. And she has actually authored one of the sources that I'm using called The Underutilization of Emergency Contraception, Examining the Reasons Underlying this Clinical Gap in Healthcare. Ms. Kit Devine found that between 1994 and 2001, nearly half of all U.S. pregnancies were unintended, with 48% occurring despite the use of contraception during the month preceding the pregnancy. In 2006, the overall rate of unplanned pregnancy in the United States was 52 per 1,000 women between the ages of 15 and 44. But the rate among poor women was 5 times that of women in the highest income level. Some of the disparity is related to cognitive functioning, access or actually a lack of access to reproductive health education, and lack of effort from health educators to ensure vulnerable populations receive the education they need and deserve. Some of the law that I found regarding emergency contraception says that since the late 1990s, state legislators have taken steps to expand or restrict women's access to emergency contraception. For example, in Illinois and Washington state, they stipulate that pharmacies that stock any form of birth control must sell emergency contraceptive pills. Several states require healthcare facilities to offer emergency contraception to all women who present and report sexual assault. Some states have actually excluded the coverage of emergency contraception under their Medicaid family planning plans in their particular state. The position statement of the American College of Clinical Pharmacy supports the right of pharmacists to refuse to fill any prescription that they feel is in conflict with their personal, moral, religious, or ethical beliefs. Although in 2009, the Federal Drug Administration ruled that most emergency contraceptive pills available over the counter to women 17 and older, but pharmacists may still refuse to sell emergency contraceptives to women based on their moral beliefs. But with such a refusal, that is called the conscience clause, the pharmacists are directed to refer the woman to another pharmacist that can actually fill the prescription if they don't have the moral objection. And they need to do this in an effective and timely manner. Emergency contraception and how it works. The World Health Organization states that over 95% of pregnancies can be prevented if the emergency contraception is taken within 5 days after unprotected sexual intercourse. The emergency contraception delays ovulation, so it actually prevents the egg from being released from the ovary. And actually, with the IUD, it can prevent fertilization by causing a chemical change in sperm and the egg before they meet. Here you will find the options available for emergency contraception. Levonorgestrel 1.5 milligram, one pill or two pill is one of the options. The one pill you can buy over the counter and you do not need a prescription if you're 17 or older. The two pill version you can buy over the counter, and if you are younger than 17, you will still need a prescription for that. And also, then you have the ulipristal acetate, and then you have the copper-bearing intrauterine device, also called IUD. Some of the side effects is menstrual changes, headache, nausea, vomiting, and dizziness, lower abdominal pain, breast pain, and tiredness. Here are the options available for emergency contraception. You have the levonorgestrel 1.5 milligram or the 0.75 milligram, which will come in with the two pills. Then you have the ulipristal acetate, or you have the copper-bearing intrauterine device, which is also called the IUD. The IUD has been said to be the most effective form of emergency contraception available, but as anyone could realize, that it may be very inconvenient to get a doctor's appointment within a 5-day period to have the IUD implanted. Important things to know about emergency contraception. There is some misinformation out there. We want to discuss use in teens, recommendations, and I've also added a YouTube video that talks about emergency contraception. While there are some side effects such as menstrual changes because you're taking a large dose of birth control or hormonal um, estrogen anyway, we would expect some menstrual changes. There also has been reported headache, nausea, vomiting, some lower abdominal pain. It could be some breast tenderness and also fatigue. We also want to talk about the misinformation. Some healthcare workers, especially those that are advocates for the emergency contraception, are very concerned that the media and internet are putting out misinformation. And some of the reasons that we see for decreased or ineffective use for emergency contraceptive is poor basic understanding of fertility, a lack of understanding of how to use contraception. We also have a lack of understanding of pregnancy risk, especially with our young people, and a widespread in both developed and developing countries. The misinformation communicated through the media and internet, such as emergency contraception causes heavy bleeding and cramps, and also causes infertility with habitual use, has not been proven. Teen pregnancy continues to decline due to better education, abstinence, and oral contraception, but teens continue to have unprotected sex. That is why the American College of Obstetricians and Gynecologists has proposed that oral contraceptives be made available over the counter, and the American Academy of Pediatrics has recommended emergency contraception be a part of the overall public health strategy to reduce teen pregnancy. The ethical dilemma for the nurse educator. Here is a quote from one of my sources, Ms. Mendez, the author of The Role of Nurses and Patients, Personal Beliefs in Nursing Care. No matter how compassionate, caring, and well-intentioned nurses are, their personal background, upbringing, education, culture, religion, and even Asian gender will factor into their character, their worldview, and the way they believe that work and patients should be approached. I looked at philosophical differences, strong religious beliefs, and personal experiences, and thought about how that could affect the nurse educator. I once had someone to tell me that no one should receive financial assistance from the government. based primarily on their parents' instructions as they were growing up to never take handouts. I was told by a coworker that I should not receive grants and scholarships for school, or not that I shouldn't, but that anyone shouldn't. Religious beliefs. Some people are raised in very strict homes and have very strong religious beliefs surrounding sexual behavior and therefore strong beliefs about pregnancy. And even if the woman has the right to choose to use birth control, personal experiences to me can impact how the nurse educator teaches students about a particular subject. Oftentimes, the nurse educator has life experiences that conflicts with his or her own beliefs and causes one to re-examine that belief. Ethical dilemma for the clinical nurse. I believe that philosophical differences, strong religious beliefs, and personal experiences also affect the clinical nurse as well. I thought about some examples here where in philosophical, patient needing help paying hospital bills. Often hospitals actually have what they call assistance for payment, for repayment, especially for those who go through a serious illness and have problems paying back, a $10,000 hospital bill. And so a person can apply for that assistance. Well, some nurses and other healthcare providers, even someone that maybe works in the business office, may have philosophical differences and treat a person differently because of their own belief. Again, here with strong religious beliefs for the clinical nurse, I thought about how mothers are treated oftentimes that are abusers of illicit drugs, and then the nurse that's taking care of the mother and the baby, and how that nurse would actually treat the mother of a newborn when they see that the newborn is detoxing off the drugs that the mother used, and she had a choice not to use them during pregnancy. Let's talk about personal experiences again, even with the clinical nurse. You may have a nurse that's treating a woman who wishes to use emergency contraception, or often even may be seeking an abortion, but that nurse herself may have fertility issues and has never had a viable pregnancy. I wonder how that nurse would be able to treat that patient, or maybe that nurse should ask a fellow nurse to take care of that patient, um, and just understanding and being aware of her own differences. Caring without judgment. We've all been there. We've all done it. We have to have awareness of self, willing to listen, and a willing to care. Some of the solutions I thought about as I thought through this for this ethical dilemma regarding emergency contraception, I thought about how nurses are caring, compassionate, nurturing, but again, as I talked about before, the personal background, upbringing, education, our culture, our religion, our age, and gender contributes to one's character. It contributes to our worldview and our belief system that affects how we care for our patients and how we interact with them. Many nurses and other healthcare providers struggle with their inner awareness of personal beliefs and how they affect situations and how they may potentially affect a way a nurse views a patient or the patient's condition and the care. So, willing to listen. Each patient holds his or her own worldview as well. And this is based on many factors in their life, such as their own culture, their religion, gender, education, socioeconomic status, career, and family traditions. Nurses must be aware of individual differences and develop the ability to relate to patients from diverse perspectives. Caring without judgment. We've all been there and we've all done it. It's hard, but we do have to have awareness of self, willing to listen, and willing to care. As I thought about emergency contraception and the ability for a nurse and other healthcare providers, I realized that, nurses, that we are caring, compassionate, and nurturing. But like I talked about before, our personal background, upbringing, education, our culture, our religion, age, and gender contributes to one's character, and it contributes to our worldview and our belief system. That affects how nurses will care for and interact with their patients. Many nurses and other healthcare providers struggle with their inner awareness of personal beliefs, how they affect work situations, and how they may potentially affect a way a nurse views a patient. We need to be aware of this at all times. We need to have a willingness to listen. Each patient has their own worldview as well, and it's based on many factors, including their own culture, their religion, gender, education, socioeconomic status, career and family traditions. Nurses must be aware of individual differences and develop the ability to relate to patients from diverse perspectives. With our willing to care, nurse practitioners and other providers who prescribe emergency contraception, especially in rural areas where there's a limited number of pharmacies. Another way they can care is by just calling ahead to ensure that the pharmacist um, is willing to dispense the medication. Make sure that pharmacist does not have an objection, a moral or ethical objection to dispensing that emergency contraception. They can also, ACOG, the American College and of Obstetricians and Gynecologists, have also recommended and endorsed prescribing emergency contraception in advance of the person having the unprotected sex, and they want to do this to expand access to emergency contraception. In conclusion, I feel that nurses and nurse educators should know the facts. We're educators, so we definitely have to educate ourselves and know what myths and misinformation is out there so that we can educate appropriately, educate our colleagues, and educate our patients. We also want to keep open communication. Our colleagues should know our ethical beliefs, because that way, if something comes along that we have an ethical or moral objection to, then maybe our nurse educator and our colleague will step in, and they can actually educate or actually participate in that patient's care, and that will relieve you of that if that is appropriate in your workplace. I also believe we should all exhibit professionalism, of course, at all times. By being open with with your colleagues and letting those in your community know what your ethical beliefs are and what your philosophical beliefs are. That helps everyone to work together. Just as it was mentioned before, if the nurse practitioner knows in advance that a particular pharmacist isn't willing to dispense emergency contraception, then we can go ahead and send that to the pharmacy that best suits that patient. Thank you for your time, and I hope that you have enjoyed this presentation. Please find the references for this presentation on slides 11, 12, and 13. Thank you.